Oh, the stream is live.
Right. I think this also might be close to the anniversary of when we graduated. So this is like,
Yeah.
it's like a med school graduation anniversary. 18 years. I think we're counting down. But now we're counting up. We're counting down.
Live. What?
Hey.
Hi, everybody. We'll get started in a few minutes. Thanks for joining.
A lot of suspense.
Oh, are we live? I think we're live. Hi, Sarah.
Hi, Graham. Great to see you.
You as well.
Just saying, it's been 18 years since we graduated from medical school, I believe.
That's right.
Exactly to the day, from the same Stanford Med class. And so excited to see you in this context here.
Thanks. Thank you to everybody that's joining us. Hopefully the technology is working well. This is our first LinkedIn Live, our first event. We're going to be talking about AI for clinicians. And yeah, I think let's go ahead and kick it off and get started, Sarah. Sound good?
Sounds great.
I'll just say, feel free to leave comments, questions in the chat. We'll try to answer them during the meeting. This is Sarah and Graham. Sarah is my good friend, classmate from med school. She's an anesthesiologist. She is founder of Validara Health, which does validations for generative AI, and honestly is an incredible leader around AI and clinician. And that's me. I'm Graham Walker. I'm an ER doctor here in San Francisco, created Offcall and MD Calc, and I like AI and clinical informatics as well.
I think Graham's trying to avoid the part where I embarrass him by saying how smart he has always been and how he started MD Calc when he was in med school and now has started Offcall and has continued to be one of the most brilliant people I've ever met. So he didn't get out of it this time.
Thank you, Sarah. Your check is in the mail. I'll just say that this really started, Sarah, because I said, hey, I was kind of scared of generative AI taking over the world in early 2023, as I think some of us were when ChatGPT was coming out, and kind of came up with this idea of the Physicians Charter for Responsible AI, this idea that, hey, physicians should have a say in how AI works in medicine. And Sarah joined me as a co-editor, wrote a chapter about the Physicians Charter. It's a free white paper, an executive summary at physicianscharter.ai. And really the goal of this is to make sure that, you know, the patient-doctor relationship stays at the center of medicine, and that AI is kind of a helpful co-pilot, if anything.
Yeah, there have been just an increasing number of kind of fear-mongering headlines too about replacing physicians and physicians being pushed out of their role within healthcare. And I think this kind of document and your leadership in this area are really crucial to maintaining that doctor-patient relationship as the key, like you said.
Yeah, thanks, Sarah. Just quick housekeeping. Please add questions, comments in the chat. We are monitoring it. We'll try to throw some of your best questions up, and we'll take some pauses and breaks to answer people's questions. We're going to do more webinars if this one goes well, if this doesn't crash and burn. So we would love to talk more. Sarah and I have already talked about, like, should we do something about generative AI prompting? But it doesn't have to just be AI. We can talk about anything really that physicians and clinicians care about. It could be finance, investing, whatever it is. We just want to like make good stuff. And we'll share this recording at the end, and we'll also share a list of tools that we've created that to help you kind of get started trying out AI and starting to get comfortable with it and be a little less intimidated by it if you are intimidated. I'll just quickly talk about Offcall. Offcall is has organized and helped us to get this webinar going. Offcall is a salary and workload transparency website that I've created along with my my co-founder Jake Horowitz, and we're trying to just build a data set. We know that physician work is not just about the dollars and cents that you make. It is about all the other stuff that makes a good job good or a bad job bad. It's how many patients are you expected to see per hour, per day. It's do you have an MA and do you have good support from your administration? You can confidentially add your information and see stuff about your specialty in other parts of the country and compare yourself. We've got a newsletter. We've got a podcast that I host. So thanks. Sign up for Offcall, offcall.com. And now we'll actually get into why you're here, what we're going to talk about. Sarah, you want to go over what we're hoping this does for people?
Sure. A lot of physicians I talk to and that Graham talked to are really intimidated, as he mentioned, by AI. And so the thought behind this was we want to give people kind of the really clinical pearls about AI. What do you really need to know? How is it being used? What can you do to know more about it? So we're going to really try to hit the high points, but we really want your questions and comments along the way to make sure that you're guiding us into the appropriate areas as well.
Yeah, I think this can be really intimidating and honestly scary. Like it was kind of scary when I first started looking at it. So we really want this to be totally approachable and easy to access. Jared Stram in the chat said he wants a prompting webinar. So Jared, I have a couple ideas for prompts in the resource guide, but yeah, I think an entire like how to with prompting is probably a great idea too. Okay. So this is kind of what we're going to cover today. We'll just go over some fundamentals. We will not get overly technical, but I do think it's helpful to understand a little bit about how AI works and how it doesn't work. And we'll tie this all back to stuff that you already use as a clinician on a daily basis, so it's not scary and intimidating. We'll talk about some real world ways that AI is being used. Then we'll talk about the jagged edge, where AI works really well and where it's maybe not so hot, and then ways that you can get started and take some action. Sarah, you want to take this one?
Yeah, I mean, I think we've all heard so much about AI lately, and it's really hard to separate what is meaningful and what's not. A lot of products and tools that we've been using for years have what we would call AI in them and have
Yeah.
for a long time. And so I think people often, now that AI is hot, now that they will put it in there when the tool hasn't actually changed, just the marketing of it has changed. And then generative AI is one type of AI, but it's not all of AI. It is where a lot of the most profound changes and advancements have come, and that's why it's in the news so much more often. But it goes way beyond being a chatbot, and there's a much wider net to AI in general. So the simple definition, which Graham came up with and I love, is computers make predictions and find patterns. So this is actually what I tell my kids when we talk about AI too. Like anything that has a pattern, AI is going to be good at. If it can find, it's going to be great at finding patterns better than we are. And so if you think about it like that, you can basically predict what it'll do well at in healthcare as well.
Yeah, I agree with your first point, especially Sarah. Netflix recommending a show to you, that is AI. Your iPhone or your Android device, as you're typing, predicting what word it thinks you're going to type next, that is AI. So AI is here. It's actually been here since the kind of probably mid 2010s in lots of products that you know. Instagram, all these tools are using AI. It's just really starting to make a larger difference because of generative AI, and we're starting to see how we could use it in medicine. And hopefully that's why you're here. This is a way oversimplification, but I think it's helpful to think of AI in kind of two flavors. Let's start on the right to be different, since Sarah mentioned generative AI. So think of generative AI if you've used a chatbot. This is probabilistic AI, meaning that if you type in the same thing, there's a probability that is applied to the ChatGPT or the Claude information. So you can type in the exact same thing, and it's going to spit out different outputs, different responses. There's some kind of creativity there. And you actually can control the creativity in generative AI and make something extremely creative to the point that it sometimes doesn't even make sense, or extremely rigid and extremely boring. And it's very regimented in how it responds. Probabilistic or generative AI powers chatbots and content creation. So if you think of ChatGPT or Microsoft Copilot, or creating an image or a video, if you've seen some of those demos, that is all generative AI. It is generating something from a prompt, from the ether, from nothing. And then on the left side, deterministic AI. Personally, I think this is the area that will be actually even more profound in the practice of medicine. Is the same input always gives the same output. If you use a model, 1 + 1 always equals 2. It's never 2.01. It's never the color blue. It's never a meatball sandwich recipe. It's always 2. And you can imagine that is a lot of what we want in medicine. We want something that follows a predictable pattern, that, if they're 87 and they're from a nursing home and they are hypoxic, it's going to give you the same answer for every single 87-year-old from a nursing home who's hypoxic. Really good for clinical decision support, and algorithms. And typically, predictive AI, deterministic AI is a bit more transparent and auditable, and we'll talk about that in a second.
And I'll just add that now a lot of the tools have a component of each. So it's
Yeah.
not necessarily all one or all the other. There are lots of tools that, especially in healthcare, will have a generative AI tool with a deterministic tool around it to give it safeguards and to help decrease the risk that the AI tool will come up with something totally crazy. So you might see that too. And that is, I would expect that's going to become even more common.
Yeah. I think the reason I called out these two different types of models is there's different stuff that we all do in the practice of medicine. And so different models are going to be helpful with different things. Deterministic stuff is going to be helpful with math, with medication dosage, with protocols. And then probabilistic stuff is going to be good with AI scribes and taking text and summarizing it, ways of taking a lot of content and changing it in some way. That's what generative AI is literally meant to do.
And it's really good at it.
Yeah, it's shockingly good at it.
Yeah.
I'll talk about this example, and then Sarah, you can do the next one. Predictive AI is trying to find patterns in noise. And this is just an example of a predictive model actually finding a pneumothorax. Now, these models can't look at images like we do, where photons are hitting our retinas. But these models can look at pixel differences, and you can imagine if it takes enough chest X-rays that have a pneumothorax on it, and it starts to find predictions like, oh, hey, normally there's supposed to be lung markings here and there's not. Maybe that's one way for me to predict a pneumothorax. Or, hey, there's a line of black pixels and then a subtle line of gray pixels where there's normally not a line. Maybe that's another way that I can detect a pneumothorax. So you can see there's different ways that these models are trying to learn, through kind of highlighting up here on the top left what's important, looking at grayscale, or looking at using a single color, or kind of combining these things to say, hey, not only is there a pneumothorax, there's actually a mass here in the right middle lobe as well.
So this is a slide from Graham's wonderful company, MD Calc. and it's the Wells criteria for PE. We've all seen this many times. As you can see, it takes 6 factors and gives you a score and then makes recommendations from there. Predictive AI, this is an example of predictive AI, but instead of the 6, you can also have hundreds of inputs in a way that you couldn't, 10 or 15 years ago. It would just have been too hard for the computer, A, for humans to identify all the possible factors, and B, to actually run those kinds of programs. So the Wells criteria distill the likely most important pieces. But just as clinicians, when we walk by somebody's room, we take in so much information about them just by looking at them. Are they lying down? Are they awake? Are they reading with their glasses on and their, feet crossed on the bed, or are they, completely asleep? All these kinds of information that we're taking in, these hundreds of data points, we don't really realize, but that's something that AI is able to do well, is to look at those and find what might be important that before we had to really just narrow down to such a small number. And that's why it can be so powerful.
I'll talk about this. This is a model that we use in our facilities at Kaiser Permanente, where I practice. So this is called the Advanced Alert Monitoring Tool. This takes, I want to say, like 100 variables from inpatients, and it's predicting who may need the ICU or who may die, and tries to then take action. So you can imagine subtle changes that maybe the doctors, the humans, have trouble noticing, like, oh, hey, the hemoglobin's just slowly trending down over the next few days, and the heart rate's slowly trending up, but it's still technically normal. Those trends, you can imagine, take all the data from the EHR, 100 data points, and that's labs and vitals and flow sheets, and maybe even the note from the doctor, patient appears mildly sicker today. Whatever it is, it's able to run these numbers and every hour make a prediction. Hey, the patient in room 1741 looks like they're not doing so hot. What are we doing to address this? And it's been, very successful at reducing mortality, addressing ICU transfers and kind of unexpected ICU transfers, code blues, rapid responses. And then finally, it's actually been effective at increasing palliative care referrals, because it's, again, bringing to the forefront of the clinician's attention, hey, this person's not doing so well, and maybe helping them prioritize a palliative care consult or a goals of care conversation with the patient or their family.
Those are all great examples, and I completely agree. And the reason I like that example especially is because it points out that there are things that humans are just not very good at,
Yeah.
which is taking a lot of different variables that are just subtly different and collating that information into an action. Whereas that pattern recognition, again, is something AI is great at. So using AI at the places that we know humans and the healthcare system in general is often not very good at, that's exactly where we want to use these kind of tools.
Yeah, let's augment the human capability. We don't need to replace it. There's just stuff that machines are better at, and that's fine. We trust the automated CBC machine every day to decide if the white count needs a manual diff, or if the automated differential is fine.
Right.
Sarah, you want to talk about AI scribes?
Yeah, so AI scribes have been all in the news lately. This one is from a bridge. This is featured because the owner or the founder is a physician, but there are many companies these days that will listen into physician conversations. They basically transcribe the conversations and then summarize them into a format that is in a note that is something that a physician might write. So the advantage of this is a few fold. One is that it may capture better and more complete information than a physician is able to type during a visit, for example. There is some evidence that it decreases for some users the amount of pajama time, or the amount of time they spend after hours doing charting, and also just kind of the burnout of having to have so many notes to write and to do every day is a real burden on a lot of clinicians. So I certainly have friends who are primary care docs who have said they just won't practice anywhere ever again that doesn't have this technology, because it reduces their workload so much. but you can see why it would work well with AI. It is able to summarize, like we said, summarization is one of its strong points. And then it's able to, because it knows patterns well, it's trained on the pattern of a physician note, and it can organize that information into that pattern very successfully.
Yeah, I've got several different AI scribe companies. There are many of these companies. Abridge is just one. I've got several in the resources guide that we'll send out and link to, all physician created and founded. And then I've got a list of, like, I think every single one from the company called Elion that does kind of healthcare tech reviews and collation. This is another example of how you might use generative AI in healthcare. The first thing I'll just I think it's important to say is, ChatGPT, Claude, all of these chatbots. I would say you probably or certainly should not be using these with PHI or PII. There's certainly some nuance in areas where you could technically use it, but because of HIPAA, because these tools are vacuuming up everything you share with it, and you cannot get that information that you've shared deleted easily. Just a call out: you probably should not be using PHI or PII for these tools because of for HIPAA reasons. Obviously, there's ways you can get around that. You can delete the age. You can delete identifying characteristics. But just a word of caution for everybody: I don't want anybody to violate HIPAA or get in trouble with their hospital or their health system or whatever. But this is a way that I frequently use ChatGPT and other models. I will give this a paper. In this case, this is a paper about ECGs and STEMI and occlusion myocardial infarction, and just ask it to summarize the paper for me. Now, there's lots of ways to prompt this to get a better response than this, a more accurate response. You could say, "Hi, I'm an ER doctor. Tell me what's relevant to this paper for me as an ER doctor." And you're going to get a different response than if Sarah says, "I'm an anesthesiologist. What does this matter to me as an anesthesiologist?" But again, this is able to take a 10-page whatever PDF and summarize it and simplify it. And I wouldn't go as far as saying this certainly is not the same as reading the paper. Hopefully you all understand that, but it helps me to understand, is this worth my time to actually read the whole paper? Like, is this, this summary looks really good. It's more thoughtful and it's a better summary than the abstract. And maybe goes into more detail than the abstract. And then it helps me decide, should I spend 20 or 30 minutes to read this whole thing versus like, this is probably a dud.
So I think we have a lot of really great questions.
Yeah, you want to pause there, Sarah, and
Yeah,
go through
I
some
think
questions?
so.
Yeah.
First of all, I want to give a shout out to BJ Lee, who's a med school classmate of ours, who's on this call
Oh.
also. And also all the other folks who have joined. So we are reading through the comments. We appreciate your participation. That's wonderful. And the questions are great. It's honestly, tough to choose amongst them. Graham, do you want to take the first shot at choosing one to answer?
Yeah, let's see. Should I go here to comments or just questions? Let's see.
While you're looking, I know someone asked about
Yeah, go
AI
for it.
commodities. That I think is certainly something that's happening in the market. And from what I've seen, more and more AI scribe companies are going into CDI, clinical documentation improvement. And then also they are doing computer use now. So being able to do things like order, like if a physician says, I'm going to order your TSH levels, and I'm going to, get a chest X-ray. They'll put in those orders on a preliminary basis for physician review prior to sending those. And I think that will go a pretty far way in helping decrease the time that physicians spend on the computer, because it's an underappreciated fact that the note is one part, but a lot of the clicking around in the chart is doing orders and sending consults and a lot of the other pieces of using the EHR that is not just writing the note. So they're expanding into that area, and then also into, as everything ends up in healthcare, into the revenue side to be able to capture the billing appropriately.
Yeah. Hi, Dave. Thanks for that question. I agree, Sarah. I think there's going to be consolidation, acquisition. Some things will go bankrupt. There'll be some specialization. So, some will go after large health systems, some will go after psychologists or social workers and find, niches. And then I think, like Sarah said, I think some will actually like try to become more of a platform. So they won't just do notes, they'll do notes and billing and to, try to kind of add features to hold on to their market share as well. Let's see. I've got a question. What would I recommend to med students today? Oh, wow. What an interesting time to be a medical student. Sarah and I were med students 20 something years ago. It's a really good question. What would I do as a med student today? I think I would understand how to do things the old way and the new way. So I think it's critically important that you, as a medical student, understand like how to critically assess a paper on your own, so that you can decide as a physician, hey, yeah, this makes sense to me. I agree with this paper or not. But I think the other thing, I work with med students and residents. I also learn a ton from medical students and residents who have a new way of learning and finding information as well. So I think there's things that medical students can certainly teach us about using AI effectively in ways that I probably have not even thought about.
The other thing I'd say is that I know a lot of med students who are more motivated to get involved in the development of these AI tools, in evaluating them, in being on the governance committees, and basically being involved in the process more with AI. And I think that's really important, is not being intimidated with it by it, one. And then also, physicians need to be part of the future and part of the solution. So the earlier you can get exposure to those kind of aspects, you're just going to set yourself up better for understanding what new technology means and which of it is hype and which of it is real.
Yeah, and med students know way more about medicine than, you may think you don't know that much, but I promise you, you know way more than 98% of the population by just being in medical school and taking med school classes. So you can be an extremely valuable asset to a startup, or you can create your own company. There's tremendous opportunity as a med student. Okay, let's keep going because this is my favorite slide.
I was just about to say it was my favorite slide.
Oh, okay. So Sarah, tell us what we're looking at here, and why is this even on the screen?
Yeah, we are looking at both parrots and guacamole, and then chihuahuas and blueberry muffins. And for humans, it's relatively easy to tell these apart, but for computers, it's actually surprisingly hard because they have a lot of the same colors. Their edges aren't necessarily in the same spots. If you think about looking at a photo and all the different angles that you can look at a dog from, and you still know it's a dog, computers can't sense that automatically, and so they have to be taught. And so being able to differentiate between these images that you can see how they would look pretty similar. I actually didn't realize how similar parrots were to guacamole until Graham showed me the slide. So that was a great learning point as well. But how it does this is go through really pixel by pixel in kind of a 9-pixel square, and it tries to predict what's going to be in the pixel next to it, and then learns from that and decides if it's right or not. And in that way, it can figure out where the edges of things are and where the edges are likely to be in different kinds of images of different kinds of things. So this is also, self-driving car technology. This is how that was able to advance so quickly. The image-based technologies in medicine are also far ahead of many of the other technologies, the text-based pieces, for the same reason that in industry in general, the image-based AI was developed really or sooner than the rest of it.
And Sarah, the way these things work is you give this computer program, say 100 images of parrots and 100 images of guacamole, and you say, okay, these are parrots, these are guacamole, and then you give it an image that you don't tell it the answer, and you say, hey, figure it out. And so just imagine this computer program coming up with, a million hypotheses about how it can figure this out and find a pattern, and just give it enough time, give it enough server flops, and it will make a best prediction. And that is, it's not that far off from how maybe you figured out which patients which patients have a kidney stone or which patients have strep throat versus viral pharyngitis, right? You see enough of these over time, you get feedback about, oh, that strep test was negative. I was sure it was going to be positive. You get that feedback iteratively, and your brain over time gets better at predicting these. And this is AI is doing the exact same thing.
Exactly.
We're just going to very briefly go over two different types of AI, and again, oversimplification. I'll cover this one, Sarah. Then you want to do
Sure.
neural networks. So machine learning is think of it as a little bit of a simpler version of AI. And again, this is a similar version to the Wells criteria, or if you've ever used an appendicitis prediction score, you take, humans took maybe 50 variables that they thought mattered for appendicitis: white count, radiation of the pain, sudden onset pain versus gradual onset, vomiting, fever, age, all this stuff. And then they pared down to the factors that mattered, and they came up with a score that you can add. Oh, this gets 1 point, this gets 2 point. Obviously a very simple version made for a simple human to add points to. Now imagine the model, you don't give the model 50 things, you give it 500 or 5,000, and you just have it run for a week. And you say, okay, figure out the best way to predict appendicitis. And so you might get something that's okay, if you're between the ages of 50 and 60, these are the things that matter the most. But if you're female and 23 years old, this thing matters the most. And you eventually build up this best model, this best fit model that tries and successfully will predict appendicitis better than all the other models from the data that you've given it. That's kind of how machine learning works. Now we'll talk about another type of AI called a neural network or deep learning.
So neural networks, this is really, what people are talking about these days when they're talking about AI. This is really where the innovation has happened. Machine learning is, I think it's helpful to point out that machine learning is what we've been using for a long time, that encompasses neural networks. It encompasses a lot of kinds of AI. So that is kind of the big circle, and neural networks are a circle inside of that. And neural networks are really, especially by doctors, best understood as neurons. And so these are different kinds of neurons. They move forward. They try to predict what the next outcome might be, and they try it over and over, kind of like a little kid, forming neurons, and they try something over and over and see what works. And then, when it works, they assign it a probability that it will work in the future, that will be that thing in the future. And those probabilities are called weights. And so you might hear the term model weights, and that is what the probability is that has been assigned in this large neural network that is created by these systems. So it can be a black box, and that's one of the difficult parts about it. With the earlier machine learning models, you were giving it the data of, these are the variables that we think might be important, go look for those. In this, it really learns on its own. And so it might be considering things that you had never thought of or that are completely wrong. So there was a paper not too long ago that showed that an AI system would predict based on a chest x-ray which patients were most likely to eat refried beans. So, it did that based on age and demographic data, and where the patient lived and who was most likely to eat refried beans in what part of the country, for example. So it may be basing decisions on things that you don't want it to base decisions on. And that's one of the challenges with these kinds of, with this technology, is that you don't know why it's giving you specific information.
Yeah. Let's pause for a second before we get into our next section and just take a few questions.
These questions are so good.
I know there's too many, and feel free to email me, and I'm happy to answer more later as well, or send me a message.
Questions afterwards too.
Let's see. There's one about AI and consent that's good. How are patients consented to the use of these Gen AI tools in these use cases? This is a fantastic question. Thank you, Jono. So it depends a bit on the health system and the local laws. There are some places that say, every time generative AI or any AI is used, you need to inform the patient. It's interesting. I think we're in a bit of a transition period where I fully agree that we need patients need to have consent, give consent to have their data and their information being used for generative AI. But I think in 5 or 10 years, we're gonna look back and think like, oh, that's crazy that we had to consent people because AI is everywhere, and how did we live without it? We don't ask for people's consent for something like using the well score. I don't, because we take that as just like a standard tool that helps us take better care and use more evidence in our practice. So I do think it's important that we talk about consent with patients. Certainly whenever anybody uses an AI scribe, I think they should get consent for the patient to be recorded and have their data, moved in. I think it's pretty rare that patients don't consent to that use case in particular. Maybe like 1 in 20 or less patients is like, nah, I think I'm good, and it's fine. That's not the end of the world. Sarah, do you have thoughts about the consent discussion as an
No,
ethicist?
I have talked to a lot of lawyers, so these kind of questions are being resolved really at the state level at this point. So Colorado and California, for example, California was one of the first to have AI consent laws. People have to be notified if they are interacting with a chatbot, for example. So there's a patchwork really right now of state laws that are being implemented. There's not a federal mandate and not a federal standard at this point. So it's really kind of case by case. It makes it hard for vendors and for a lot of health systems cover more than one state. So they're kind of trying to make sure that they're complying with all the different state regulations. But I think ethically, people want to know if they're talking to a person or not. There is interesting data about whether they like the interaction more if it's a chatbot or not. So when they don't know that it's a chatbot, they often like it better than talking to a person. And then when they know it's a chatbot, they then don't like it as much.
Yeah.
So it does influence patient experience. That knowledge does influence patient experience. I think is a piece of that too. Like it does change people's opinions, so they should know. But I agree with Graham that in 5 or 10 years, I think when I interact with a United chatbot, I assume that it's a chatbot.
Yeah, I do too. At this point, I assume it's just a chatbot, and maybe eventually I get to a human, or do I? Or is it just like a better chatbot? I don't know.
A chatbot with a name. Yep.
Yeah, yeah. Let's move on. We'll try to get some more questions toward the end. I just want to make sure we have time here. So we're going to talk about Sarah. Maybe describe what's the jagged edge or the jagged
Sure.
frontier of AI.
Yeah, this is from an Ethan Mollick paper where they looked at BCG consultants and they randomized consultants to either using AI or not using AI and gave them kind of normal consultant tasks. It was a pretty big study. They used 7% of BCG's workforce to do this, and the interesting, like everyone's performance improved using AI for the most part. So the worst performers improved by 43%. So it brought them into the median, and the best performers improved by about 17%. Interestingly, the jagged edge piece specifically comes from the fact that when the AI system was not very good at a task, people tended to lose about 15 to 20 percentage points in performance. So they didn't override the AI and they didn't go around it to make their own judgments. Instead, they kind of trusted it too much and their performance decreased. So the point is that AI is great at some things and bad at things that you would expect it to be very good at. So it's superhuman in some areas. For example, protein folding prediction. The AlphaFold. That's what the Nobel Prize recently was won for. That's by far superhuman. It used to take us. I did chemistry research in a lab. It would take months to years
Months. Yeah.
yeah, to figure that out. Now it's literally seconds. But at the same time, a lot of the models are still bad at literally adding. The most recent versions are a little bit better, but math is really hard for them. So there's
Math is hard generally.
I think that's what Barbie said,
Yeah.
um, but yeah, so I think that's an important thing to understand and why it's so important to use these tools so you get a good sense of what it's good at. And that's why Graham and I keep harping on, these are the things that it's good at and these are the things that it's not, because understanding that helps you use it really well. And if you don't understand it, your performance is going to go down, just like
Yeah.
with these consultants.
Yeah, so Sarah and I think, are both cautious optimists on AI and healthcare, but we also want to knock it down appropriately and kind of warn people that it's not perfect. It will probably never be perfect, but especially for this talk, we think it's important to talk about the downsides too. It's not just all roses and glory. I don't think that's a phrase. So I'll cover over reliance here. This is kind of a foundational one, so that's why I started with it here. This is just This is just a fact of human nature. When you start to use some things more, stuff that maybe you used to do manually or yourself, you get worse at those things. And we are seeing this in AI as well. So if you start to use AI for everything, your clinical gestalt is going to get worse. Your being able to come up with a differential diagnosis on your own or in your head is going to get worse. Or thinking of that rare syndrome that you're going to get worse at that. If you start using AI too much. There was a small trial looking at colonoscopy assisted AI, or AI assisted colonoscopy, where if they gave people access to a tool that helped them find polyps, and then they took that tool away, well, some of the endoscopists got worse at finding polyps afterwards, because maybe they weren't as focused on the task because the AI was so helpful. How are we going to not lose our skills? I don't know. I think there's some med students that are going to be really important in helping us figure this out. There are ways that we've done this before previously in medicine. We often use video laryngoscopy in the ERs, but it's nice. Many of the tools now, you can actually just use a regular Mac or Miller blade, and the attending can see what the resident is doing. So it can be a really helpful way of not losing your skills, but also having the assistance of a technology. So I think we'll figure this out. But it's an important one, because the last thing we want is for all doctors to get either lazy or bad at their jobs, or not know how to do a lumbar puncture because AI has been doing it so well for whatever process. Sarah, you want to take the next one?
Sure. The bias is a big focus. It's one of the main issues that hospitals are dealing with right now when they implement AI systems, because interestingly, a lot of the insurance commissions, for example, have laws, the regulations say you cannot provide a biased product. And so you have to make sure that the AI products you're using are not biased. And from an ethical standpoint, of course, also, you don't want to provide patients with biased care. That's the last thing any of us want to do as physicians. So we want to decrease bias, but we also need to realize that it's always going to be there. That people are biased. We can't pretend that humans are not biased. The AI systems learn on biased materials. There's data about when clinicians write things in quotes. That's a sign of bias often. And the AI systems learn from all of that. And also the big models are trained on things like Reddit. I mean, I don't think anybody thinks that
And
Reddit
Twitter, yeah.
and Twitter, like, those are not unbiased sources.
Yeah.
So understanding that it's going to be there is more important than saying it's never going to be there. Figuring out how to mitigate the risks and to design systems that provide good care for everyone, despite the bias that humans and AI systems um, uh, introduce into our care, is really important. And Graham makes a great point here too, that AI can actually amplify the bias, and that's one of my real concerns, is that it may not just be additive in terms of you know I'm biased plus the AI is biased. It may really take those biases and like we said, sometimes we don't know why it makes predictions or why it does things. It can really cause those to be even more marked than they would have been otherwise.
Get you like way off course. Yeah. Yeah. Black box is a term that means you don't know what's happening inside the box. And so you can't, the AI model can't really explain itself. And even if it could, again, because of the neural networks, like Sarah demonstrated, the explanations might not make a lot of sense to you. So even if you tried to force a model to explain itself, it might say, well, why do you think the patient has appendicitis? Well, because they're 37 and their heart rate is ranging from 67 to 94, and their white count is normally 12.7, and today it's 12.9, and it's a Wednesday. Might be so many little permutations that you're like, you might actually trust it less. And the other problem here is, how do you know if the model is correct, or if you're correct if you disagree? Is the model a false positive or a false negative or a true negative or a true positive? Especially if the human clinician is going to be responsible for that outcome. Say I think it is appendicitis and the model disagrees. If I'm right or if I'm wrong, is that my fault? Am I going to have medical legal responsibility? Is the model? So I think this is going to be a challenge for us all to figure out. And I'll just say, it also is why I think it's really important that we maintain our clinical skills and not get over reliant, because I think ultimately the human is going to be the arbiter for quite a long time about, like, do I take this person to surgery? Do I start you on chemo? Do I start this medicine that comes with some significant risks? So I think it's really going to be a challenge for us to figure out what the right thing to do is, and we'll have to come up with structures to figure out how to do that and agree on the right thing to do.
Totally agree. And I also want to just acknowledge how many great questions we're getting here,
Yeah.
and keep them coming. We will answer them after the fact. So don't think that just because we don't answer them live here, we're trying to get through this content. And we're so excited about it that we're talking a lot about it. But we will answer these questions. And so we love this participation, and we really want to hear what your questions are, and we will answer them.
I can probably honestly, even like, if we don't get them to them today, maybe I can turn them into a Google Doc or a LinkedIn post or something too.
I
'Cause
think
they're
we can. Yeah, we can
fantastic.
figure out a way to
Yeah.
do that.
Sarah, you want
So
to do
yeah, medical
med legal?
legal. This is something that I've been working on a lot lately. I think the word mess is appropriate. Basically, nobody really knows what they should be doing. There's no real standard of care yet for AI. There's no standard in terms of what is acceptable, what is an acceptable level of risk. And there are a lot of pieces of that. So one is, what is the context? Is it something that's being done really poorly right now? I think that's something with ambient scribes. We already know that 50 to 80% of what's in a patient's note is wrong or incorrect or old. So an ambient scribe being, maybe 95% accurate and having 5%, losing 5% accuracy, maybe that's not such a big deal if the current state is so bad. So that the contextualization is one piece that's kind of missing. And then the other part is physicians as absorbers of malpractice. So that, right now we are serving that function of absorbing this malpractice. And I don't think that I know that hasn't been resolved at a legal level yet. So people are just kind of waiting for these cases to come up. And when I've talked to to actuaries, what they've said is, we don't know if people are going to award larger payouts for the same injury if an AI system did it versus a physician. And we don't know if the payouts are going to be larger if the physician ignored the AI or went with the AI even when the AI was wrong. Will there be a difference with that? And how much will that change our malpractice liability? We don't know. So those are things that will come up in the next few years. Everyone's quite confident that those lawsuits will be brought, but until there's case law to help define what that means, we're all just kind of trying to do our best to adhere to standard of care in terms of the usual suspects of what we think about for standard of care.
Brad asks, will the AI resent us if we assign it too much scut work? I hope not, Brad, but if they really are like humans, the intern AI will definitely resent us. Adam want me to run these questions through an LLM. Adam, if you want to run them through an LLM, I can answer them independently, and then we can see who gives the better answers. I'm worried it's going to be the AI though, because it's going to be more comprehensive, because I can't type as much. I'll cover the last one here. You probably have heard of hallucinations. If not, this is the idea that is often described as confabulations, a nice medical term, because these models will sometimes give you totally bogus information, and confidently say it. So these models don't know that they're saying the wrong thing. What these generative AI models are doing is they're just trying to predict the next word, and they're trying to make you happy. They're trying to please you and answer your question. As you may have seen with the current administration, they put out a Make America Healthy Again document, and it had hallucinated several citations that were not real papers. They were totally fake, but they looked really real. They had citation, they had the page number and the journal number and the year and the journal title, and were in like whatever APA format, and so they looked really real. Now, these hallucinations have improved markedly since just ChatGPT 3.5, which was just 2 years ago, and they will continue to improve through the technology and through better uses of the technology. But hallucinations may never fully go away. And so these things can make errors. And then there's also errors of omission. So a model might give you a really good recommendation for treating a UTI, but if you don't tell the model that the patient's pregnant, it's not going to know that, and it's going to give you a very different answer than what it may tell you if it knew they were pregnant. And so again, you need to be cautious with these tools. I kind of say don't trust, but also verify. These tools can be extremely helpful, but they can also lead you totally astray, and they won't know that they're leading you astray. They won't tell you, and they will just, and it could be buried in, it could give you 5 paragraphs of text, and there could be 1 sentence about the dosing of Bactrim that could be just flat out completely wrong, and it won't flag that. It won't know that it's giving you the wrong information. We are rapidly getting towards 6 o'clock, so we're going to fly through. Just like Sarah said, some of these AI does things really well and way better than humans do. There's like a reason that we use Excel. Computers are really good at math and numbers and finding patterns. So that's what AI is really good at. Carrie, you want to talk about how it's being used today? I think there was even a question about prior auth in the chat as well.
Yeah, so these non-clinical uses, I think, number one, it shows what doctors are desperate to not do and to offload, and those are some of the first things that it was used for. So the first thing people started using it for was prior auths, and very understandably so. It's really good at summarizing information and putting it into different kinds of formats. So it's, if you tell it, give it a role, you tell it what kind of format to be in and what it's trying to do, it'll do a great job of that. You can give it the same information and put it into lots of different formats. And quality metrics also, again, extracting data and looking for patterns, and then claims and billing. I'm sure everyone's heard about the unfortunate claims and billing side from the insurance lawsuits. So there's also that side to it, that you then have 2 AI agents talking to each other, which I think we can all agree is just a broken system on top of a broken system. And then, the clinical pieces are being introduced, of course, more cautiously. So radiology, the image-based fields in general are really adopting it more quickly because the technology is more advanced. Risk prediction is kind of, I would say, slowly being adopted.
There's pockets where it's used, but it's all pretty slow. Yeah.
What I always say is, I live in a ski town, in the winter, I walk by somebody with a bone sticking out of their ski boot. I know what they have. I don't need an AI system to tell me what they have. So, the risk prediction, I think it's something that engineers tend to love to create, and physicians tend to not be so excited about, because it's also kind of like a fun part of their job to figure out what to do. You do the differential and figure out what's actually wrong. Chatbots is great at talking to people, and it can be incredibly helpful for patients, especially in that kind of context, and for boring things like finding where policies are in a hospital's website. And then ambient documentation, as we already discussed. And those are really the main places where it's being kind of widely disseminated, I think, right now.
Yeah, Sarah, I really just think if you do a residency, you're probably very well trained most of the time. And so there's so much stuff that's I don't need help with this one. I know exactly what is wrong with this person, or I know exactly what treatment it is because I went through a grueling residency that like forced me to
My
learn.
neural network already knows.
Yeah,
It
yeah,
needs
yeah.
another neural network to help me out. Yeah, exactly.
Humans are real well-trained. Humans are really well trained. Okay. In our last few slides here, I just want to call out, from a social perspective, there's a lot of stuff that we do in medicine that our patients need that have nothing to do with AI. That the best AI system in the world is not going to create housing or fix prior auth or get rid of PBMs or make a cab voucher appear for my patient or like help people. Force people to exercise. Maybe it can motivate them and it can help them pick better foods at the grocery store or on the menu, but it's not going to force them to eat those foods or get their steps in. And there's going to be AI will get more and more integrated into the EHR, but the EHR is far from a perfect system as well. I think one of the reasons I'm so passionate about this stuff is I think there were some challenges with how the EHRs were rolled out. They started out as really good billing platforms, and it's really taken a very long time for EHRs to really focus on UI and usability for nurses, doctors, pharmacists to use them as best they can. And then AI is not going to magically make nurses or doctors appear that have left the profession because they've burnt out or they're tired or they're exhausted or they just don't like working in healthcare anymore.
All right, we got 5 minutes, and I also just want to say, I'm so excited that there are over 100 people here
Oh,
listening to
amazing.
this and commenting, and it's wonderful. It's late on the East Coast, and it's after a long work day everywhere, and thrilled to have so many people engaged in this discussion. Let's try to see how many slides we can get through in the next couple minutes here.
Yeah.
I think, like Graham was saying, it's not everywhere because it's not needed everywhere, for one thing. And then also workflow integration is huge and always underappreciated by AI vendors and the people who often make decisions about what AI tools to buy. Clinicians never underestimate these because they have to use them
To
all the
deal
time.
with them. Yeah.
Financial barriers. Some of these tools you can't bill for, and so they're just straight costs to the hospital. And hospitals, as we all know, are basically always trying to find ways to cut costs. Evidence gaps. It's hard to show improvements with a lot of these, even when they look great on paper. Once they're actually introduced into the complex web of healthcare delivery, they may or may not actually be as helpful as you think they should be. And then, there is a degree of clinical skepticism. I think that will change as people become more comfortable with it and
Yeah.
as they learn how to use it well for the things that it does well and not to use it for the things that it is pretty useless for.
It is poor at. These are I think our last maybe 2 or 3 slides. If you see an AI tool that you think is kind of interesting, maybe you see it on social media or your hospital talks about it. These are the things that I think you should think about and kind of the questions to ask. Hey, how much is a human still involved in the decision making here? Is this helping me or is it replacing me, or replacing decisions? Is it been validated? Just it's kind of similar to like any other medicine or tests we might use. Is it been tested in my population? Like Sarah said, is it go into my workflow or do I have to like open 3 different browser windows and log into 3 separate systems to get this thing to actually work? And how annoying is that going to be and slow me down? Always consider that especially generative tools can be incorrect. Does it make and meet face validity? And then like, how accurate is this thing? Is this, oh, great, it's slightly better than a coin flip? Well, it's probably not a great use of your hospital's resources or your time to try out the tool.
The other thing I'll just say, I know we're short on time, is just that I think physicians are sometimes worried about raising their hand and looking stupid to ask some of these questions. And I would really encourage people to go ahead and ask what seem like dumb questions.
Yeah.
I think you'll be shocked by the number of times that people have not considered them or don't have a really good answer for what you're asking. I think once the word AI is in there, physicians sometimes get worried about looking dumb. And really, these are the kind of questions and the kinds of issues that physicians are most skilled in and have the best opinions on. So really, please ask these questions of any AI tool that's introduced.
That could not be better said, Sarah. Yeah, I think these companies often probably don't want physicians to ask questions because they might have to show their areas of ignorance. This is what you're going to hear about in the next coming year, and may already be hearing about, is agentic AI. So not just a model that can chat back to you, but can actually take actions. It could book a plane ticket for you if you gave it permission to do so. If you hear the word multimodal, that just means not just text, but imagine video or images or audio. So it can process other types of data. You can paste an image into ChatGPT and it can interpret that image and describe it to you. So that's multimodal. More automation, so AI or just automated tools that can handle automatically refilling medicines if it's within certain parameters. And then I do think we will have reduced hallucinations by having models talk to other models and verify the information first. So there are ways that we will see hallucinations decrease further over the next few years as well. Just try this stuff. That is why we've got a resource guide for you guys. You are not going to hurt anyone. Don't use PHI, but play around with this stuff. Find out where it works really well. Try to make it hallucinate. Try to figure out ways that you can have it screw up. This is how you'll learn, okay, I could see this being really helpful in this type of patient, or in this, the half day a week that I work in the pre-op clinic. This could be really helpful for this, but it wouldn't be very helpful in some other setting. Talk with other people about AI, ask questions, like Sarah said. That's so important. I've got a list of newsletters and communities you can sign up for and YouTube people you can watch. There's so many ways to learn. And I think we just need more and more clinicians talking about this stuff, having a voice, and finding a way that we're going to impact AI and make it work for us and make it work for our patients. Otherwise, it's going to be done for us. And I think we've seen that previously with the EHR system. I don't think it worked out as well as it could have.
I just also want to say that when you by trying stuff, it doesn't have to all be clinical. So this is stuff that you can do with your family. If you have young kids, you can have them type in, I want a coloring sheet of a unicorn on a teddy bear with a flower on top, and it'll make that. And then you can print it out and they won't talk to you for 15 minutes. It's maybe exactly what you need to actually learn about this stuff clinically. But, it can also, but you'll learn what it's good at. If your kid has a project and they say, what about this random person from the Civil War? You can tell them to go ask Claude, and Claude will tell them all about that random person. And you will also learn what Claude is good at, how it explains things, and just get more comfortable using it on a regular basis. So I would encourage you to not just use it for, think that this is work and I have to use it only for clinical uses. You could, use it in other settings as well.
Yeah, I almost exclusively use it for non-clinical stuff, honestly. I have played Dungeons and Dragons with ChatGPT.
I have not, but I've made a lot of coloring sheets.
It was pretty fun. Okay. Please sign up for Offcall. Thank you, Offcall, for hosting this event. Offcall.com. We're really trying to build a data set that helps physicians get through their day. We've got newsletters that you can sign up for that are not just Offcall, but AI newsletters. Try a tool. Attend an AI session at your next conference. I guarantee you every medical conference is going to have something about AI. And then if you really get into this stuff, become like your AI representative for your department. Every department is going to need one. And feel free to email me. I will answer any question you have. Let us know if there's other talks you want us to give. We've already got an idea for a prompt Gen AI talk. And then I've just got this, we'll email this out, but this is a list of resources from different generative AI models to YouTubers, to newsletters, to communities online that you can join. Yeah, thank you guys all so much for watching. We'll, Sarah, I can stay on and take some questions if people are still around. Yeah. Let's see if there's any questions here. Oh my God, there's so many questions. Thank you guys so much. This is incredible.
I know, and they're like really good, well-informed questions too, and really insightful and interesting.
I see. Can I click that? Oh, look, Nuber. Hi, Nuber. What administrative tools do you like rather than clinical besides Scribe? I would love to kind of enable our like quality team to use AI. There's got to be some AI tools that are looking specifically at like quality metrics and tracking. I think there's so much paperwork and regulatory stuff that could be massively improved with AI. Last year, I judged an AI competition with the out of pocket healthcare team. One of the ideas I liked best was just like a chatbot that helps people sign up for Meals on Wheels or Medicaid or services that they qualify for, and just simplifies filling out a 9-page PDF by turning it into a chatbot. So I just think there's a ton of regulatory kind of back office stuff that AI could drastically help our patients with, us with as well.
So these are things also like the VA, for example, which has a very complicated protocol-based process. Anything that has already written down rules that are very thick and well detailed, that's a great use case for AI in general. It can take that and put it into natural language. It makes it so patients don't have to read through 50 pages of a PDF to know how they can access their VA benefits. They can say, I am this and I have this percent benefit. What is actually covered for me? And it can tell you. So anything with that starting format is always going to be a good use case.
Let's see what other questions I've got here.
Specific practical tips to get engaged in the idea generation and testing of new AI use cases within institutions. So, AI governance committees are forming in most large institutions now. Most of them are under resourced. I think most of them would be very happy to have some volunteer help. And it's a great way to get in on kind of their you know they're forming, and so it's an opportunity to learn and to have some input and to understand what kind of issues people are really trying to figure out. So I think that's a great way. As Graham mentioned, every department needs somebody to say this is how AI applies to us and our specialty within both the national community and our specific specialty in our specific clinical setting. So being able to put all those aspects together to be your institution's voice and your department's voice about this is what's most important. This is what it's going to be best at for us and our specific situation. People need people who understand that and who can advocate for the kinds of tools and ask those right kinds of questions that are really meaningful, so we don't spend a whole bunch of money on stuff that doesn't work. And if we do that, then the AI is going to go away because people are going to say it's useless when it could have been great.
Yeah. Let's see. Any last questions? John Ludlow, shout out to John. Hi, John. Do you use deep research modes for any complex clinical questions? John, I use generative AI very little for medicine because I think I'm a pretty decent ER doctor. And I also don't want to get into, I don't want to have the risk of any HIPAA or PHI stuff. But I have used deep research for my own weird body quirks. So John is referencing this, that there's a mode in most of the AI models now, generative AI models, called deep research. And think of it like it'll go search the web and it'll like really process things. Instead of giving you an immediate answer, it might take 5 minutes or 3 minutes or 60 seconds to give you an answer, but it's internally talking to itself and trying to give you a more comprehensive answer. I've asked it about my weird heartburn symptoms, and it gave me actually a really interesting response about, backed up by numerous papers that were real papers on PubMed, about like why I might be experiencing certain kind of weird atypical GERD symptoms. And I thought it was actually a really helpful tool. So if I'm using it that way, I'm sure many of your patients are already using it that way as well.
And I think open evidence, no affiliation, but I haven't used it for any of my actual clinical patients, but open evidence that when I've used it on, tried to make it hallucinate, so far I haven't had it hallucinate any medical references either.
Well, I know we're 10 minutes over. Thank you all for watching and staying so long, and on this busy evening Tuesday. Thanks again for watching. Sign up for Offcall. Download this document here. Yeah, it's been wonderful. Thanks for our first webinar.
Yeah, thanks everyone. Really enjoyed it. Thanks for all the participation. We really appreciate it, and we will get back to those questions.
And thank you, Sarah, for joining me.
Thanks, Graham. It was a treat, as always.
All right.